Dr. Suma Ganesh from Delhi, and she will be speaking on approach to pediatric strabismus vertical squint analysis. Little complicated, so keep your eyes open.
No, I'm going to do a little bit basic only. I'm sorry if there are only speakers. I thought so. I would first thank the scientific committee for inviting me here and respected chairperson and co-chairperson, sir. So I would be speaking on vertical squint analysis and management. So this is a child who has right hypertropia. Now, how do you distinguish it? See, the other eye, one eye is coming down, and the other eye is going up. So this is a true hypertropia. Okay. So now you see the other eye is coming up. So this is how. In the next, this is a child who has, if you see here in this video now, this eye is coming down. The left eye is coming down. We are doing it with the Spielman's occluder. The right eye is also coming down. So this is DVD. Okay. So this is how you differentiate between a true hypertropia and an alternating hypertropia. That is a dissociated vertical deviation. So the simple test helps you to distinguish. So and this as a child, the other this hypertropia where you can have is when there is a you will get a nystagmus. See the nystagmus which is there? So this cyclovertical nystagmus is normally seen in DVD, dissociated vertical deviation. So there is a latent hypertropia, latent DVD here. So that's how we differentiate. And the surgical, I put the management, but the surgery for a simple DVD is a superior rectus recession, depending on whether it is unilateral or bilateral. So you will do superior rectus recession for a mild, moderate, or a severe DVD. So you can do up to 10 millimeter of recession of superior rectus. And if it still doesn't work, you can still do a Farden. So now you can have an incomitant DVD when there's associated inferior oblique overaction also. So here you have, there is an inferior incomitant DVD, there is a inferior oblique overaction and a DVD. So for this, the surgery is not only doing, you have to do a inferior oblique anterior transposition. So basically you want to take care of the inferior oblique overaction also, and you want to take care of the DVD also. So now how will you measure it? So when the eye is coming down, so the first you will get that there is hypertropia. When you're measuring, first the eye will come down, the other eye is going up, and then you keep on measuring, and then you find that one stage it is neutral, but still the eye is coming down, and then you know that there is an hypertropia, and there's an inferior oblique overaction causing the hypertropia, and there's also a DVD. So we can measure like that, and that's how you will plan a surgery for an inferior oblique anterior transposition when you have both of them together. So this is how you will investigate and see. So this is where you place it just at the level of the inferior rectus. So this causes it causes a depressive effect, and that is how you will treat a inferior oblique overaction with a dissociated vertical deviation. And to prevent an anti-elevation, you will put both the bites together and you cause a hump like this. So this will prevent the anti-elevation. And you place it at 0 station. If you place it at 1 station, then you can get a overaction, or you will get an anti-elevation syndrome. So a true hypertropia, which cases we'll get in a congenital superior oblique palsy, if you have a superior oblique palsy. Normally there will be a compensatory head posture. Then you can have facial asymmetry like this, like a hypoplasia in one side. And then you will have to do what the test is. You have to do a Parkes 3-step test. So whenever you have an hypertropia, you need to do a Parkes 3-step test. That is, you do first in the primary gaze, and then you do it in the gazes, and then you do it in the tilts. And then with these, I'm not going to the details of this because just 7 minutes. So, but Parkes 3-step test, you can come to the diagnosis of whether it's a superior oblique palsy or whether it is a superior rectus paresis. So if you have a right hypertropia increasing on dextroversion or on levoversion, increasing on levoversion and tilt to the same side, then we know it's a right superior oblique palsy. So if you have a right hypertropia increasing on right gaze, increasing on right tilt, then you have a left IO. So you just need to know these few things fast in your clinic to understand what the pathology is. So always in a superior oblique palsy, the tilt will present with the opposite tilt. In a child presenting with the inferior oblique palsy will come tilt to the same side of your palsy. So these are few tips for your clinic so that the vertical squint don't get hassled by it, but it's not so complicated also, it's not so easy also, but you don't have to get this. Hess chart is important. So in this case, you can see there's this Hess chart where it's showing you a right superior oblique palsy. And you can do a diplopia charting where you will see also. Now, if this is a diplopia charting, so you have the outer image is the eye affected. So here you get the green. So we have put the red in the right eye and the left, and that's the green which is affected. So this is the algorithm for the superior oblique palsy, which is there in Rosenbaum. So if there is the important thing for the investigation is a forced traction test, and forced traction test tells you whether it is very lax. If it is very lax, then you need to do what is called as a tuck. Always think bilateral if you have alternating hypertropia and if there is a V ESO and down gaze. Okay, so that's why you need to measure in up gaze and down gaze whenever you are measuring. If you are seeing if there is alternating hypertropia, so you have a V ESO and down gaze, which will tell you that this could be a bilateral superior oblique palsy. Now you have a child with eye not going up, there's a chin up, limitation elevation, left hypotropia. So what are the two diagnoses you can have? Either it's a Brown's or it's a IO palsy. So now to Brown's we know that all these things are present. So how do you differentiate? Mainly we'll have a FDT is the test for differentiating between a Brown's and an ioparesis. And in a Brown's we'll have a V pattern in up gaze and hypotropia. So now this child presented with a hypotropia. Everywhere it was written as Brown's, but there was an A pattern. So it is important for us to check all gazes. Now in an A pattern does not occur in Brown's. So you are thinking of something else. So you do a IFDT on table, and then you find that in FDT that it's a tight tendon telling you. So in this case it was not a tight tendon, but if it is a Brown's it will be a tight tendon. So the surgical procedure for if there is such a procedure for superior oblique Brown's, then you can either do a chicken suture or you can do superior oblique tenotomy or a tenectomy. And for A pattern with an ioparesis, you can also do, if you have a torsion, yes, you have to do a superior oblique tenectomy. If you don't have torsion, then you do a chicken suture for the A pattern. Okay. So I'm just telling you the clinical. That was my topic. So this child, we did a superior oblique tenectomy. And a right superior, because there was also a DVD, I did a right superior rectus recess with so that because it's an A pattern, superior rectus is an adductor and up gaze. So when you do a recession, you will get the A pattern also corrected along with your DVD correction. Last case, where this is again hypotropia, 30 hypotropia with an XT around 20 prisms. There's ptosis, true ptosis, and the eye does not go up. What is it? It's a double elevator palsy. Okay. So you also have to rule out, put this in the other eye and see whether it's a true ptosis or a pseudotosis. So here it is a true ptosis, and then what the plan is, basically you do an FDT. So the important investigation everywhere where you're doing is an FDT to rule out whether it, in a vertical squint, to rule out whether it is restrictive or paralytic. So if you have a restrictive, then you do an inferior rectus recession. Now if you don't, it's not restrictive, and you find that there is the superior rectus is paresis, then you will shift both the muscles, horizontal muscles to superior rectus for the paralyzed muscle. So that's called as a NAPS procedure. So all these cases, you have to know whether it's restrictive or paralytic. So FDT seems to be the investigation of choice. So to summarize, we need to check for the abnormal head posture, facial asymmetry, the deviation. Parkes restep is important. Ocular movements are important. Do bilateral for vertical squints. Sensory evaluation, Hess charting, diplopia charting, and evaluation of torsion. Thank you. What I could cover in 7 minutes.
You see, it's really complicated. The only complicated topic in strabismus is the vertical palsies. So she has done very good work, and in a very short time she has summarized. Naturally, she can't show many things, but these vertical palsies have to be, actually done only when you are a strabismologist or you do a strabismus surgery. So, thank you very much, Suma.